back to another episode on the PlantFueled Femme. Today we have a special guest with us, Kim Vopni, the Vagina Coach. If you don't know Kim, she is a PT with pelvic floor health specialization, and we are here today to talk about pelvic floor health. Thank you for joining me, Kim. I'm so looking forward to our conversation.
Thank you. I appreciate you having me. It's something I'm very passionate about. And just to clarify, I'm a personal trainer, not a physical therapist. Just sometimes people think I'm a physical therapist, but just wanted to add that disclaimer in there that I apply fitness principles as a personal trainer to this group of muscles called the pelvic floor.
Right. No, I love that. And I think that's something that I should work better on differentiating. I just don't even think like when you're a personal trainer for so long, you just don't even think about it. Like PT means personal trainer, but PT also means physical therapist. Yeah. So Kim, you said you're very passionate about this topic, which I followed you on social media for a while, and it's easy to see that you're very passionate about this topic. And I think that a lot of us end up in, the areas that we work in because we've had an experience that's, kind of driven us to learn more in this one specific area. So how did you get into this specialty of pelvic floor health?
Really, I've always, growing up in my life, I've always been curious about the body, curious about health, fitness, nutrition, and I've always come from a preventive mindset. And when I learned about, sex ed and childbirth, I looked at that and thought, well, that looks terrible. And then went and talked to my mom and knew that she had issues and watched her sort of change her life and alter things as she was navigating getting older, going through menopause, that type of thing. And so it was sort of this, well, I'm not interested in that. I will just avoid it. So I thought I just won't have babies. And then when I, grew up, met my now husband, decided I did want to start a family. I had that then, okay, if I want to avoid what I was witnessing my mom go through, what can I do? And my midwives had recommended a biofeedback device to me called the Epino. And it's a medical device from Germany. Epino stands for no episiotomy. Episiotomies are where they cut through the perineum, the tissues of the, close to the vagina on the perineum during childbirth with the intention of creating more space. And that sounds logical. It would make things easier, but it really created more challenges. So with the aim of reducing episiotomies, which my mom had, or reducing the likelihood of tearing, this product made sense to me. I purchased it, had a great experience, and then thought, why doesn't everybody know about this? And that was really the catalyst that got me into this world of pelvic floor, coming from this lens of if we can prepare for childbirth, viewing it like a physical event we would train for, like a triathlon, like a marathon, like a bodybuilding competition, why wouldn't we do that? And why aren't we doing that? And this is a tool I felt could be helpful. So that's kind of how it started. And then, I was helping people. I created a program called Prepare to Push, very much train with the principle of specificity for childbirth. Then I was saying, okay, we're doing all this work to prepare, but we're overlooking this recovery piece. And recovery is part of any training protocol. And when you look at other cultures around the world, they really honor the recovery, postpartum recovery, and we don't. We just completely disregard it here. So formed a second business, started working on trying to bring in many of the practices that other cultures do into a more modern day lens, created a postpartum wrap and exercise recovery protocol, and juggled that space, prenatal, postpartum, for many years. Then I started to go through the menopause transition, not knowing what the heck was happening. The term perimenopause wasn't talked about at all. This is, 12 plus years ago now. I had no idea what was going on, but it just, as I was learning and trying to figure things out and understanding what was going on, it highlighted there's this whole other chapter, perimenopause, postmenopause, and really pelvic health is something we should be talking about through all the different life stages. So it started very much with me wanting to prevent things. I did prevent tearing with this product, but that didn't make me immune to pelvic floor dysfunction. So it's not as easy as if you prevent tearing, you won't have any pelvic floor challenges. You don't ever have to have even been pregnant to have pelvic floor challenges. And so through the process of my learnings around that, then my learnings of how I could overcome what I was now facing when I was experiencing pelvic floor dysfunction, my business has sort of followed and evolved with my own personal journey, really. And And yeah, and I keep saying to my pelvic floor, I've got enough personal experience now. Thank you very much. I don't need any, don't need any more, but hopefully I don't have any other surprises coming along. But anyway, that's sort of how I got into this and what keeps me going.
Right. No, I love that as life has progressed, that the business has just kind of followed along with you. I think it's incredible that you started like pre-pregnancy, then you have the postpartum, and then through perimenopause. Like that gives you, well, the whole cycle. I love that.
Yeah. Yeah, absolutely. So I'm now 5 years post menopause, and the majority of the people who are in my community are in that, approaching menopause or maybe even beyond menopause for 10, 20 years, some of them. And that really emphasizes to me that this is a problem people or a topic people only think about once they have a problem, and they're only taking action once they have a problem. Really, I came from the place of we should be preventing this. And I do see now more and more people have awareness about pelvic floor health and are working with pelvic floor PTs, are taking the steps during their pregnancies. But
Mhm.
you don't ever have to have been pregnant. So there's a whole other group of people over here who aren't even getting that information now.
Right.
Really, we should be getting this information when we learn about bodies, sexual health,
Mhm.
um, fitness when we're younger, our menstrual cycles. We should be learning about the pelvic floor at that time so that we are prepared for all of these life changes. Because I will tell you that menopause transition was a lot in terms of all the changes that were happening, learning about that. And if you're also navigating pelvic health, children, job, aging parents, it becomes a lot. And if we knew ahead of time, I think it would save a lot of angst and silent suffering that goes along with pelvic health.
I agree 100%. And I love that, it's the preventative side that you focused on. And I think that's a fantastic approach. Everybody should have it. We were talking a little bit before we got on the show, and I said if everybody knew how to walk, it would prevent so many problems. But fortunately, we forgot how to walk and we forgot how to breathe, which are two very foundational things. And you're right. Like inside of education about the body, we're not taught about the pelvic floor. Even inside of like most prenatal care, you're not like there's no education on it. So it leaves it going outside of the medical system to find education on. Well, since I'm going to be having like all of my tissues expand, is there anything I should do to prepare? And a lot of people don't think about that. But you're right. People that are pregnant, that have never been pregnant can still have pelvic floor issues. Men can have pelvic floor issues. They will never be pregnant. And if we could go back to square one, education, I think that would save, like you said, a ton of frustration and a lot of problems.
Yeah, 1000%.
Yes. So inside of like what we should have learned for pelvic floor health prior to pregnancy. Then we have, like you said, the most important part is that recovery piece. And it's not common here, and I think it is somewhat in the other countries, that recovery piece. Women are given access to pelvic floor health PTs, where they can develop a program based on women's needs, post pregnancy. That's something that's not seen here a lot yet. Is that still correct?
Yes, absolutely. And I think I wish and hope that at some point in my my lifetime, I see that it is adopted worldwide where it is just built into part of the healthcare system. There are many parts in Europe where it is an automatic prescription for anybody who has given birth. It's also available to people who've not given birth. It's just not, it's a prescription you need to ask for. Whereas if you've given birth, it's
Mhm.
automatically provided to you. That's the only difference. But that plants a seed about bringing awareness, conversation, the importance of care for this part of the body. Whereas again, it's just a taboo topic here. Even on social media, we couldn't say the word vagina because it was inappropriate, and all the barriers there that are up that are part of what contributes to the silent suffering associated with pelvic floor dysfunction. And if we again receive this information earlier, it whether you become pregnant or not, yes, it should be part of prenatal education. It should be part of fitness education. It should be part of the certifications of people becoming personal trainers, fitness instructors, Pilates, yoga. You know, it's, if we're learning of all the other muscle groups and the origin, insertion, and the function, why are we not learning about what is the foundation? What is the most important group of muscles for transfer of load through the body, the foundation of the core? We
Mhm.
need to be learning it at that point. And then it can serve all people, regardless of their phase of life. But again, if we're tackling this earlier, it just plants a seed about how important it is and gives people the tools and an understanding of who the healthcare practitioners are that can help us. So many people still, I've been talking about this for 20 years, still, I've never heard of a pelvic floor physical therapist before. So they're the veil is starting to be lifted now, and more, you know, it's finally trending. Pelvic floor is finally trending. And it happened in the prenatal space first, which is great. It's still, I wouldn't say 100% done, but the conversation around menopause, which has exploded, especially in Hollywood and the celebrities, that has fueled a conversation around pelvic floor health as well, because of the sort of subcategory of genitourinary syndrome of menopause, which is a lot of the common pelvic health struggles that happen that are either brought on or exacerbated by that menopause transition. So my big overriding mission is get the information out there, ideally get it out there earlier, and take away the myth that it's only something you pay attention to if you have a problem.
Right. Yes, no, it goes back to that pre-education, which I absolutely love. So inside of like, I guess, caring for or even understanding the pelvic floor, what is like one thing that would help people be more aware of that, hey, I even have a pelvic floor in the first place, and this is what it's supposed to do.
Mm-hmm. Yeah, people can do a little bit of self landmarking. So sit in a chair, lie down on your bed, and find the bony scaffolding of your pelvis. We most of, you know, if you put your hands on your hips, you're very cross about something. That's part of your pelvis.
Mhm.
If people touch the front part, they will often say the pubic bone. That is a joint, actually, an intersection of two bones. That is an attachment point for the pelvic floor. People may have heard the term sits bones. If you've ever done yoga classes, sometimes they'll talk about the sits bones, or they may, certain poses you might feel those, especially if you're on a hard surface chair. Those two, the ischial tuberosities, are attachment points for the pelvic floor. And then at the base of our spine, we have the triangular sacrum, and at the tip end of the sacrum, we have the coccyx or the tailbone, another attachment point for the pelvic floor. So understanding those 4 points, this sort of diamond shape where this group of muscles attaches, is helpful, I think. It's also helpful because these muscles are inside the body. They aren't muscles like we can't go to the mirror and flex our bicep. We can flex our bicep, we can't flex our pelvic floor per se and see it in the mirror. Even if we held a mirror between our legs, we may see a little bit of minute movement, but we see the external genitalia. We don't necessarily see this group of muscles that we can really flex and relax or stretch. So visualization, imagery, and ideally working with somebody who's trained to evaluate and assess and treat the pelvic floor can be very, very helpful in terms of helping people understand where this group of muscles is, what it does, what maybe some of the symptoms you've had that you didn't even associate with being something that could be associated with the pelvic floor. So having the visualization of where it is, and then now an understanding of what it does. So this group of muscles, it's 3 layers of muscles. It's not just one muscle, it's a group of multiple muscles in 3 layers. The outer or first layer, primarily responsible for our sexual response. Second layer, primarily responsible for the openings of the urethra, the vagina, the anus. Third layer, primarily responsible for organ support, bladder, uterus, rectum, intestines. And we have all heard the term core exercise, core workout, pelvic floor being the foundation of that core. It's responsible because of its attachment points at the base of the spine, on the pelvis, to manage load and help us with core control and stability. And it also works in synergy with the diaphragm. So every time we breathe in, an ideal response, which should be happening physiologically in the body, is the pelvic floor is expanding and lengthening. And then as we exhale, the pelvic floor is contracting and lifting. So there's this synergy between the two that is considered optimal function. When there's a disruption to that synergy, then we may start to have some symptoms. And so you've got the visualization, you understand the jobs of the pelvic floor. Now, some of the more common signs and symptoms: leaking urine. Stress urinary incontinence is leaking urine when you don't want it to come out of the body, some sort of exertion, laugh, cough, sneeze, jump. We leak a little bit of urine. This is what the pad companies tell us it's just part of being a woman or just part of getting older. Maybe even a care provider says that's what's happened. That's what happens after menopause or after you've had babies. This is very, very treatable and not something you need to accept. Pads do not need to be just something that is part of your destiny. Urgency, frequency, like urinary urgency, frequency, also common as we are getting older for various reasons, not something you need to accept. Oftentimes a result of prolapse, low estrogen, dehydration, constipation, things that people don't think about. They actually stop drinking urine thinking, well, if I have urgency or if I leak a little bit in urine with my exercise, if I don't drink water, then I won't leak or I won't have those urges, but it's actually contributing to more problems. Anal incontinence, leaking gas or stool, much more life altering, less common, but more life altering. Then you can have prolapse. So this is where the bladder, the uterus, and or the rectum, sometimes the intestines start to shift out of their proper anatomical position, bulge into, descend into the vagina. 50% of women who've given birth have some degree of prolapse, and nobody's ever heard about this. Nobody screens for it. This can happen to anybody, even people who haven't been pregnant. It can happen to anybody at any stage. More likely if you've had babies, more likely as you get older. More likely if you're constipated, more likely if you chronically cough, more likely if you have a heavy occupational job. Then you have the pelvic pain category, and this could be pain in that bony scaffolding, pain in the muscles, pain in the tissues, pain that we, with even no touch, we feel, pain with insertion, lots of different categories of pelvic pain. And again, I've listed a few of the contributing factors, but things like posture, constipation, dysregulated breathing, anxiety, stress. I think I said constipation already, chronic coughing, low estrogen, pelvic organ prolapse can contribute to some of the other symptoms as well. If we think about what is typically offered as a solution, anything to do with pelvic health, go home and do your Kegels. That's all we're offered. And it's when you think of how complex this part of the body is, all the ligaments, the tendons, the muscles, the layer of muscles, the blood flow, all the jobs that it has. How can we think that one Kegel exercise done multiple times is going to be the cure-all for everything? It's not helpful. It's not accurate. Kegels can help. We have evidence to show when they're done correctly, when they're done consistently, when they're done for the right condition, they can be effective. However, I still say even if it is done correctly, consistently, and for the right condition, it still misses out on the opportunity to train the pelvic floor dynamically as part of a whole body system. We think about the pelvic floor in isolation, and we have to isolate the pelvic floor. Whereas that's not how it works. That's not how anything in the body works. It works as part of a team and synergy and coordination. So we need to train it that way. So that's kind of a way just to at least get the landmarks, understand the jobs of the pelvic floor, understand maybe that some of the symptoms you have could be pelvic floor related. And then the person to see is a pelvic floor physical therapist. That should be like your dentist visit once a year. Go see your pelvic floor PT, even if you have no symptoms. Just have a checkup, because we do age. We do face challenges that could influence our pelvic floor. So if we can have somebody help us screen for and check for these things so we can catch them ahead of time, and also be, brushing and flossing. Our brushing and flossing for the pelvic floor is the pelvic floor muscle training, right? So we have to play an active role in that as well.
Yes, I love that idea to just see a PT once a year. Like maybe you don't need maybe you do need intensive therapy, but maybe you don't. But maybe you should pay attention to this. I love that. And I just want to say, I did not know that 50% of women have prolapse. That's crazy. And it's not talked about at all.
The thing with prolapse is it's very, very common. And part of the reason I do recommend we see a pelvic floor PT is because early stage prolapse, it's graded. In North America, we grade it 1, 2, 3, 4, with 4 being the most advanced. And that's where we would have a visible bulge outside the opening of the vagina. Very advanced. It can take years for prolapse to develop. And early stage prolapse is often asymptomatic. So if we are catching these things early, we are in a position of preventing it from getting worse, maybe improving it, maybe reversing it completely. And it's not just a go home and do Kegels and that's going to fix it. We have to look at other contributing factors. If that person is straining to poop every single day, I could give you all the exercises in the world, even a whole body approach to pelvic floor muscle training. But if you're constantly straining to poop, first of all, it could be a pelvic floor issue, but also it's going to be damaging to your pelvic floor as well. But super, super common. And it is the one that really halts people in their tracks, the diagnosis of pelvic organ prolapse, because people become very bothered by the symptoms if they have them. They, even if they don't have symptoms, they now have this image of something quote unquote falling out or could fall out. So now they're afraid to move, they're afraid to jump, they're afraid to do anything, thinking they're going to break something or make things worse. And sometimes they might even be told, oh, you can't lift anything over 10 pounds. Oh, you can't jump anymore. And there's no evidence to say the pelvic floor can't manage X load. There's no evidence to say that. So we've just come up with this arbitrary number that then people get attached to, and now they become afraid of moving. But when you think about, so many people go to the gym and they're afraid to lift because their doctor said don't lift anything over 10 pounds. Well, I bet you've had a bag of groceries that's greater than 10 pounds. I bet you your suitcase when you're traveling is greater than 10 pounds. I bet your grandkids are more than 10 pounds. We just have an association. We don't think about all the other little things. But it's avoidance doesn't build resilience. And so we need to train for life. We need to train for all these things. And the pelvic floor needs to be a part of that. It deserves its own exercises. We can combine it into our workouts and train it in all these different ways so that when we lift groceries, lift grandkids, we're less likely to experience symptoms or have that be a contributing factor to the development of symptoms.
Right. Creating the resilience. That's brilliant. I think in your list of symptoms, you did mention that estrogen could be a contributor to pelvic floor dysfunction. I think for most of our audience, that might be something that we want to look into.
It is, especially as we are approaching our menopause. So perimenopause, generally 6 to 10 years prior to the onset of your menopause. Menopause being one day that marks 12 consecutive months without a period. Beyond that, you're now postmenopause or menopausal. There's different ways of using the terminology. And a hallmark of that transition is perimenopause, fluctuating hormones. And we sort of are coming to a place of low hormone. And estrogen, all of them really, but estrogen is sort of the one we think about most in terms of the role that it would play in many of the symptoms. And now specific to the pelvic floor, the vulvovaginal tissues, the bladder tissues, estrogen is what helps the tissues stay juicy, supple, lubricated, have good blood flow circulation, and helps us prevent infection. When we no longer have that estrogen there, we now become much more likely to experience infection, especially UTIs. We may experiencing things like itching, burning, irritation, sandpaper sex, changes to the structures. We might start to see our labia disappear. We may not be able to experience orgasm. We may not even be able to accommodate insertion. Genitourinary syndrome of menopause, or GSM, is, again, that whole subcategory of this menopause transition that affects the genital system, the urinary system, and sexual symptom. What did I say? Genital, urinary, sexual. Yes. And so many of what we've talked about, pelvic pain, incontinence, prolapse, fall under this umbrella of GSM. So if you haven't had these symptoms already, it may be this loss of estrogen or this transition phase that brings these symptoms to the forefront. We know that upwards of over 80% of women will experience one or more of the signs of genitourinary syndrome of menopause. So another place where we can say, hey, let's not wait until we have these, knowing the majority of women will. Let's intervene early around the start of our menopause, sooner if symptoms indicate, with hormone therapy, specifically vaginal estrogen in this situation, or vaginal DHEA. Some people may even use both. And this will help keep the tissues supple, juicy, robust. It will help keep the blood flow optimized. It will help prevent that thinning, drying, irritation, itchiness that can happen with the tissues. It provides more support, so we're less likely to experience incontinence, urgency, frequency, waking up at night to pee, prolapse, all the things. And we know from research that there was a study that looked at 50 postmenopausal women who were dealing with, in the study, they used the outdated term vulvovaginal atrophy. It's now GSM. And they had them in mild, moderate, severe categories. And one group was all of them actually did Kegel exercises as their first intervention. And Kegel exercises do help. Like, we know exercise helps blood flow and circulation. So that can help many people. When they then had the additional, the addition of vaginal estrogen combined with the Kegel exercises, they had greater remission rates, especially in the moderate to severe categories. So it's like peanut butter jelly. They work better together. And Kegels help, or pelvic floor muscle training helps deliver the estrogen to all those tissues. So it's the hormone piece can't be overlooked. There's been a huge rise in awareness, in large part due to doctors like Dr. Rachel Rubin, Dr. Kelly Casperson, who created a petition to the FDA to change the black box warning label that was scaring the pants off people and preventing them from using this beneficial, very well established therapy. And that black box warning label was medically inaccurate. So that has now been removed. There still, though, is this hangover of people think that estrogen is dangerous, estrogen's going to kill me. Not using estrogen could kill you. It's one of the UTIs are one of the major contributors to sepsis, urosepsis, which can become life-threatening. So again, we always are we wait until there's something that we have to fix. But when we can intervene prophylactically and prevent these things, we're in such a better position.
Yes, that is amazing. I had no idea that the UTI situation was that bad. I know it's bad, but that is horrible. And it's something, like you said, you can prevent it.
Yeah, 1,000%. And UTIs so they become much more common post-menopause because of that loss of estrogen. Because estrogen is the food for the lactobacillus. We should have a lot of lactobacillus in our vaginal microbiome. That's one thing. It helps blood flow and circulation. That's another thing. But also, when we don't have the estrogen there, the tissues, as I mentioned, they can thin and dry, change. We can lose our inner labia. The tip of the urethra can become more exposed. So that increases the risk of infection, as does the lack of food for the beneficial bacteria. It changes the pH of the vagina, so it's much less acidic. So all those reasons why it's so much more common to experience UTIs, and women struggle with them and are put on antibiotic after antibiotic, and that's also destroying your gut microbiome and your vaginal microbiome. Vaginal estrogen.
Yes. Yes. And it's such a simple thing. It's unfortunate that that label was on the estrogen for so long. It really is. There's so many women that were scared for so long.
1,000%. And we have a hangover of women who missed out. We have a hangover of physicians who weren't trained, and that is changing pretty dramatically now. There's a lot of education. There still is a lot of work to be done, but we're moving in the right direction.
Yes. Yes, which is what is important, is going in the right direction. So at the very beginning, you mentioned that you're not a pelvic floor physical therapist, but I know that you have created many programs for women. So these programs that you've created, I do want to talk about them a little bit. You mentioned that you have some for prenatal, then postnatal, and now like for the perimenopause and menopause population. With the programs that you offer, I do understand they are not physical therapy, which everyone does need to have if it's a pelvic floor assessment to see what your body needs, which is different than what someone else's body needs. But the programs that you've designed are to help women with like the fundamentals, correct?
Yeah. And I think, again, I apply fitness principles to the pelvic floor, and just like us applying, you know, creating a fitness program for somebody standing in front of us, we do some general screening of major health considerations, but we may not know everything about that person. And that person could achieve success and achieve many of their goals without having seen another therapist or rehab professional ahead of time. And the same goes with the pelvic floor. Not everybody has access geographically, financially. Some may not want an internal evaluation with a pelvic PT, and that shouldn't exclude them from being able to benefit from pelvic health education. So while I absolutely recommend we all see a pelvic PT, you can still learn a lot and do a lot and figure a lot out on your own when you have the right information. So that's where my program comes in, is teaching people a lot of what we're talking about here. I use a lot of imagery, visualization, things like my vulva puppet and my pelvic anatomy models to help people self-identify. And then I take them through a whole body approach, part of that being fitness, but also being lifestyle, posture, breath work. How much are you sleeping? How hydrated are you? That type of thing. There's lots of little buckets we can address that can help people make significant change, even if they aren't able to see a pelvic floor PT. So I work very collaboratively with pelvic PTs. I'm always referring on to them. Many of them will refer their patients for the home care. So pelvic PTs do the internal work, assessment, treatment, but they're also very busy and they have wait lists and they can't be monitoring and creating these fitness programs. So that's kind of the role that I play to help people support the home work, so to speak, that then helps support the work that they might be doing with the PT. The other piece, initially, I had separate programs, prenatal and postpartum and perimenopause, menopause. Now, really, it's one collective community because the principles really stay the same regardless of your phase of life. Yes, a couple of modifications for certain positions in pregnancy, but other than that, it's the same principles. So now everybody is in one community following the same general recommendations with some support for the nuance in there. And then there's also a pro course because, again, I said all the certifications I've ever done, personal training, fitness instructor, pelvic floor was never mentioned, and it needs to be. And until that point, we need this additional exercise. So for people who are a personal trainer, are a fitness instructor, yoga instructor, and are working with women, I consider it essential information. So they can come and take my pro course and have that understanding of how to screen for pelvic floor dysfunction, work collaboratively with the pelvic PTs, and be able to create fitness programs that are designed to help support and improve symptoms of pelvic floor dysfunction. We're not diagnosing or treating anything. We're not teaching you how to do that. That's for the pelvic PTs and the medical community. But that doesn't mean that we can't play a role in helping optimize the function and fitness for these people and help them manage their symptoms.
Right. I love that. I didn't know you had an educational course too. That's great because you're right. That's like it's an empty spot in the room. And most of the people that pursue personal training are women.
And
So
most of the clients are women.
yeah. So it's just it's something that's very needed.
Yeah, 1000%.
Well, that's really cool. So Kim, where can they find more information on your program?
My website is vaginacoach.com. My main community is called the Buff Muff community. And all my social media handles are at Vagina Coach. I also have a podcast called Between Two Lips, and I have written a book I have a few books. The main one, Your Pelvic Floor, is a pretty good foundation for people to learn no matter what phase or stage of life they're in. And that's available on Amazon or most major bookstores.
Oh, awesome. And you've written a few books. Okay, cool. All right. Was there anything else that you wanted to share with the audience today that we didn't cover?
A big message I have for people is, yes, I talk a lot about let's prevent, let's don't wait until you have these problems, but a lot of people find out about this when they have been struggling for maybe years. It's never too late to make change. It's never too late to overcome incontinence, to start using vaginal estrogen, to work on your bowel movements, to make change. There's always an opportunity for change. And the oldest person in my community, that to my knowledge, is 93. And I love that she came in open-minded, willing, thinking, I've never learned this before. And she was 93. She wasn't accepting that I'm in my 90s, it's too late for me. And we have so many women who are in their 70s, 80s, not as many in their 90s, but usually in their 70s, 80s, who now are kind of they're part of what's fueling the mission. They're telling their granddaughters, they're telling their daughters, so that we can change the trajectory for the next generation. So I want people to know it's never, ever too late to start paying attention to your pelvic floor.
That is a powerful message. I absolutely love it. Well, thank you so much for your time today, Kim. I truly appreciate it. I think this was a very, very valuable conversation for our audience. So thank you very much for your time.
Thank you for having me. I appreciate it.
Absolutely. And to all of our listeners, thank you for joining us, and be sure to tune in next week.